Hi everyone, Assalamu alaikum, and a very good afternoon. Welcome to our Medjack webinar. Um, well, for starters, we based this webinar off of our book that we published. The book's called Medjack. It's AKU's first digital book, and print versions of it are also available. This book has been written by a total of 14 co-authors. And it is basically a compilation of all the work that CCIT has done so far. So why feel the need to start these webinars? What we essentially do is select a chapter from our book and then invite a guest speaker and then give that speaker a chance to share their journey around innovation, creativity, and entrepreneurship. For today's session, we have with us as our guest, Dr. Simi Rahman, who is an AKU MBBS graduate of the class of 1997. She's a United States-based integrative and psychedelic medicine and transformational healing expert. She is currently the founder and medical director of Bala Medicine, where they help their clients take advantage of the powerful healing potential of psychedelics. Hi, Dr. Simi, so good to have you, and thank you for agreeing to be a speaker for our webinar today. How are you doing?
Oh, thank you so much. The privilege is mine. It's wonderful to be back at my alma mater, and I'm really looking forward to this conversation.
Great. And good to have you. So the moderator for today's session is Dr. Asad Mian, former chair of emergency medicine at AKU and director of CCIT. Hi, Dr. Asad, how are you?
Hi, Marine. Thank you for having me moderate this session. But Simi and I go back a long way. So.
Great. So just very quickly, a bit about the chapter we selected for Dr. Simi, and I'll start with a quote. Well, it says, it has been said that next to hunger and thirst, our most basic human need is for storytelling. And it's a famous quote by Khalil Gibran. So chapter 5 delves into narrative medicine. We wrote about why pursue it, why we felt there was a gap, and how we at AKU here at CCIT proceeded to fill it. What our findings were in terms of outcomes and impact, further evolution and progression because of COVID-19, how narrative medicine helped us, how we've used it as our toolkit, and what work we've done, and how then we further progressed into Jugaad Innovation Challenge from there, right? That's what chapter 7 is about, challenges and opportunities. So that's potentially what we'll be speaking about. Please do note for people joining us online, if there are any questions, comments, or suggestions, please feel free to put them in the chat space provided. And we hope that this turns into an interactive session. So over to you, Dr. Asad.
Great. Thank you, Marine. And once again, thank you so much, Simi, for being a speaker. Just to give a bit of context to this particular session or this webinar that we're having with Simi. So for the folks who are online, there are people over here, but I don't know whether they're listening in to us. There's a lot of chatter in the back. There's activity happening over here, Simi. Anyway, so people. Simi got together with our team, CCIT, I think it was a few months back. And that was a fireside chat with Simi. And at that time, we wanted to get her take on, we want to understand her journey of innovation. She might not overtly be calling herself or considering herself to be an innovator, but we believe that everyone is an innovator in certain ways, and a creator certainly, and an entrepreneur as well. And so Simi has checked off all of those boxes. And so we were talking to her about her journey, what kind of work she's been doing, and so that indicated to us that that conversation could be morphed or could be evolved into today's webinar. And Medjack webinars this is the third year that we've been running these webinars, and for this year it's the second webinar. So that was that link from the earlier chat we had with Simi, and it also helped us figure out what kind of conversation we want to have with Simi. And so several years prior to that, Simi was our workshop facilitator, and she was a keynote speaker for us for that particular workshop, and she also became a facilitator somewhat the time difference between Karachi and LA, I believe at that time, notwithstanding. So that was really interesting, that particular experience, because we were just getting familiarized, or at least I was, with narrative medicine. And so Simi had been working on the field of narrative medicine. So my first question, I'm just going to get into that question, and then we can have a bit more context to what we did the first time around. But Simi, I think it'll be fair to assume that most people listening in to us are not familiar with narrative medicine. So let's start there. What, if you could briefly tell the audience, what is narrative medicine, and what's been your connection to it?
Thank you, Asad. Our interest goes back to writing about our experiences in medicine. Asad and I have always shared that interest, and this kind of understanding that sharing stories from inside of medicine brings a lot of value, not just to the people reading the stories, but to the people writing them. So I'd say that telling stories that move people to feel, to act, and to bear witness within the healthcare space is narrative medicine. It's a term that was coined by Dr. Rita Sharon from the New York Presbyterian Medical Center, she's an internist who also did her PhD in English literature. And she basically took the lens of critical appraisal that you look at all text with, all literary text with, and she applied it to the clinical experience, to the actual interpersonal relationship that happens between the physician and the patient, for example. And there were quite a few things that were noted. You might have heard of, how long does it take a physician or provider to interrupt a patient before they speak, right? 18 seconds. We know that the narrative within our healthcare spaces are truncated, are not given the space to breathe. And so the importance of narrative medicine really became clear to me. And when I attended the Examined Life conference in Iowa, which is a conference that is held with the medical school, as well as the Iowa Writers Program, which is probably like the kind of leading writing workshop in the US. And so when I found that conference, I felt like I had found my people. There were ICU doctors writing poems about night shifts. There were just a whole range of authors talking about the internal experience of illness, whether they were patients or whether they were physicians, kind of blended, because all of us are eventually at some point patients, right? We all cross over that line. So that is where my interest kind of started about 15 years ago. And it's just kind of grown as I've branched off into medical education.
Great. So, and then could you recall for the audience, what was the reason for you to participate in the workshop that we did at AKU several years back? I reached out to you, I remember that, but Dr. Murad had actually shared a paper with me, and that was your paper, and that you've written about narrative medicine. I'm like, oh, wait a minute, I know. And of course, he knew you as well, he recalled you from. So that's when I reached out. And so what was your motivation to be a facilitator for that particular workshop? And what was your learning based on that first workshop that we did? And did you find any differences compared to narrative medicine workshops in the US? And you've taught medical students using storytelling as an approach to medical education. And so did you find any differences between the two groups?
That's quite a few questions. I'll try to take the first one. And thank you for, it's so lovely to know that Dr. Murad is still continuing with his interest in writing, because as I remember, that was one of probably my first earliest, faculty examples of doing something outside of medicine that enhances what you do inside medicine, that really, informs it. And gives you a greater sense of what you're doing in medicine. And I think that's really what attracted me. For practical reasons, I started to understand as a medical teacher that within the clinical spaces, our time and our ability to connect with people's stories was diminishing. You know, and I realized also that the storytelling impulse and the lens and the skills that I already had were starting to help me be a better clinician. And as I started to kind of see that that transfer of skills was necessary, for example, we did one of the first curricula that I got introduced to was the art observation curriculum that they do at the Museum of Modern Art over here. They would have an art docent taking around medical students. And what they would do was observation exercises. And we know that observation is probably one of the most important skills as a physician, is to really be able to take in as much as we can passively from a context of from a story. And just those exercises where we stood as a group, we exchanged information, and we tolerated each other's difference of opinion, because modern art is just that way. You know, 5 people look at the same piece and 5 people are going to have the different interpretations. And so it became clear to me that part of what narrative medicine does is helps us to communicate with each other about our own experiences, our own thoughts and ideas about what we're seeing and doing, and that it gives us a space to deal with ambiguity, for example, in that space. So I started to research it. I actually am very fortunate to be mentored by somebody who considers Rita Sharon her mentor. So Pam Schaff is my mentor at USC Keck School of Medicine. And with her, we did so many different you know, courses, first years, second years, third and fourth years, even in residency, and really just tried to see exactly what you're saying, like, you know, how acceptable are these curricula? Because you introduce anything into the medical school curricula, and most people are like, please don't put more in here. This is crazy, you know? So how do you insert what you feel is an important set of skills into an already kind of overburdened curriculum? And I am proud to say that the University of Southern California has the second ever narrative medicine master's program. The first one is at Columbia. And so really, you know, looking at it from a scholarly angle, like you guys are, you know, that you have been doing since that webinar, and just the group that you've done, that is the piece that really matters, is just familiarizing everybody. You know, you put narrative medicine as one of the chapters in the book. That was amazing. You know, just elevating it to the level of importance of everything else, or some of the other skills that we need, tells people that, yes, this is important. Even if I don't understand it, it's important. What I will say is, whenever we talk about narrative medicine, I've learned that the class kind of splits into 3. There are the people who really love it and are here because they know what it's about and they know how it functions, and they're the ones who've written before or have already an interest in writing or reading or literature in some way and can see how those things connect. The middle, you know, kind of group are going to be the ones that are like, okay, I get it. I think I need to learn some of these skills because I think it'll help me, you know, but I don't care about all of the kind of nuances and the philosophy and the, you know, structure of why it works. And the third group is like, I don't like this. I don't understand why you're doing this in a medical school, and I don't want to be here. And here's the funny thing: after doing 6 to 8 weeks with this whole group, what you see is the people who had no idea why they needed it or were actually resistant to it experienced the most growth. Because for the first time, because some of that resistance comes from a sense in medicine that, you know, I've got so much to do. There's just so much here. We don't have extra energy for stuff, you know? But when you experience being able to express yourself, being able to tell your story in a way that connects you with your group or with another human being, and really sometimes these stories have been in us for a while. You know, when you ask somebody to write a story that really means something to them in medicine, it could be something they've been carrying for a long time, but they don't understand why. And it's, you know, and that permission that is given to go ahead and put words to what was just a feeling or a thought or a memory really brings that memory alive, reactivates it, and also connects somebody to, okay, why was this story so sticky for me? And then they understand it. And then that informs them a little bit about themselves and who I am and what I'm becoming, you know? So I would say when it comes to the 2 different audiences, I think, AKU just attracts an amazing, cross-section of individuals. And I've always found this great creativity there. I don't know if you remember it, but, Asad, music was a big part of our life on campus. We were a class that bonded over talking about anything and everything. We just really had a good experience of being ourselves with each other. And I still carry that. I wrote that article in JAMA. Really, it was talking about AKU. It was talking about how the digitization of medical education has taken away what we had. So, we just took for granted at AKU, which was the fact that we were all at med school and we were all just stuffed together and forced to interact with each other, and we couldn't escape. And the digitization of medical education has meant that I talk to my students, my coachees, they're in like their 6th month of first year. And I'm like, do you know the other students in your little 10-person group? And they're like, no, I don't know all of them. And I'm just stunned, because it means that they are now getting an experience of medical school that is not sufficient. I really think, that's why I think since that first webinar, I think the importance of narrative medicine has become even more as a skill set that's just eroding, because we were able to develop these things from just, you do 30 hours in the hospital, you talk to people, you have time, you're writing things down, you're not typing on a screen. All these barriers weren't there for connection, and now they are. So I really think even increasing the emphasis on narrative skills is going to be part of what medical education, innovation.
Thank you. Any questions or comments? Okay, we got some people here and they're very interested. I know one in particular who's really interested in narrative medicine. And so Arfa, you probably will have some question or comment, right? Not now or later.
Please feel free.
Okay, that's fine. Yeah. Ajay, I put her on the spot. Ajay, say so I some of the thoughts that you had shared with me while we were thinking about the format for this particular webinar. And so one of the things that you'd mentioned really connected well. You'd said unleashing the power of storytelling as an innovative and underutilized resource in the healthcare continuum for both patients and their physicians, particularly those in training. So let's get into storytelling as an innovation, let's say, something that's been underutilized, and you're making a case for this, for using narrative medicine or storytelling to improve the healthcare continuum, let's say, right? So what would you expand on that?
Oh boy. That's a big question. I think the part of it that I can chew off right now is that when we talk about practitioners in healthcare, the reason storytelling became important to me was that I was walking around with a bit of a fragmented story. If I may just kind of communicate my story to the audience. When I came to AKU, I was not yet 18. I'd grown up in Dubai, pretty sheltered. My parents are from Bangladesh. And one of the first questions that was asked to me was, why are you going to Pakistan? That was a fractured story. And to me, first of all, because it had a great school and it accepted me. That's why I'm going to Pakistan. Number two, I never had any animosity. We never did, towards any of the history between Pakistan and Bangladesh, because we grew up in Dubai. We just had a very multicultural upbringing. We had a lot of friends from all across. And I spoke Urdu as well, and my Urdu just, improved. I know that as I learned in Urdu, there was a lot of fun made of my accent and all of that. And there was no problem with that. It wasn't seen as something fractured. And so to me, knowing the history, knowing how powerfully it affected both countries. I remember Dr. Shoro, very beloved professor of anatomy, who one of the first classes that I'm standing next to, our cadaver, he comes in and he starts singing in Bengali. He started singing a song that you would hear like people, who are like traveling by boats on rivers, like romantic songs. He was a very romantic guy. And poetic as well, which I think in medicine is part of it. You know, we're talking about the poetry of the human condition. We're talking about the body, which is just, you know, it took me till like a couple of years ago or very recently to understand that poesis and poetry share the same root. Right? I mean, we're used to this idea of poesis, right? So to me, storytelling and poetry and putting meaning together and stringing things together is creation. It's poesis. It's making something new that didn't exist before. Because we all have fractured stories that don't kind of make sense, you know? So storytelling really helped me to understand, okay, why am I here? You know, what do I do with this experience that I've had now for 6 years in Karachi, you know, and how does this fit into my story? And those things are iterations. You know, I've written multiple times, told the story in multiple ways, and the story has grown with me. That's the other part of narrative, is that you are writing. When you write, when you reflect and you make a journal entry, you're making a gift to your future self. That's what I tell my students, especially in medicine, because we go through so much emotional just stuff, right? Things we have to process. We accept a lot of things, emotional, you know, kind of content from people. We get pushed a lot in our boundaries. We are asked to be very coherent in our narratives as well, because we're asked to tell of ourselves in a way that makes sense. And over time, the more and more I've done this work, it's made more and more sense. And that's, you know, I think the greatest thing about narrative medicine is that it's a sense-making tool, because it allows other people's perspectives in. You know, so let's say I've heard a story and I've only heard one side of it. When I insert the other perspective, I've just created a story. It's like, oh, there's two sides to the story, and somewhere in between those two sides is the truth there. And it allows us to then triangulate to the truth a lot better and operate from that place, instead of, you know, and checking our own biases and checking our own kind of preconceived stories sometimes that we have, right? So being aware of what we're telling ourselves about a situation allows us to think differently about the situation and have control over things. And that turns into reflection and action, you know, that turns into a skill that you can deploy as things are happening and really understand, okay, do I need to say anything right now? Sometimes even silence, you know, is a narrative, right? Silence can just be like full of significance.
So to tell me, you've mentioned a fractured story. And so what do you mean by a fractured story? Is it a story that's incomplete? Is it a story that there's been trauma to oneself, pain in there, or searching for meaning? What is a fracture? Because I've come across this concept of fractured selves, right? So what is that?
Absolutely. Great question. Because, you know, unless we kind of look at the stories we carry and examine them and say, okay, where did I get the story? You know, how did I come to believe this? And if I do carry these stories with me, for example, the fractured story that I kind of came upon when I went to Pakistan and stepped onto the campus was that the version of 1971 that I had heard from my family and my, you know, country people and read and everything was very different from the story that I was hearing was being taught or told in Pakistan, right? And that is where the fracture of, you know, just the story of my parents, you know, came to the forefront. So my parents were both physicians. They were training in med school. It was in their last 2 or 3 years of training that the disturbances started to happen, you know, a lot of political unrest, and their exams got delayed over and over again. And so one of the things that, you know, I think stayed with my father was that was a very difficult time to go through. And so, you know, my father was the greater storyteller of the two of us, and he always, you know, was trying to reconcile events, trying to reconcile relationships, and trying to reconcile what we saw in the world with what we did about it, So it's very easy to get locked into a fractured story and say, well, I take a side, right? I choose to see it one way and not any other way. And as I learned more and more, as I got to know people, as I developed friendships and had relationships and really, spoke Urdu in a way that my patients would be like, "Acha, aap kahan se hai?" Like, Pakistan mein aap kahan se aaye hain? So it's very important to me to kind of blend in and carry those two stories together and see what I could find in them for myself, see what kind of what expansion it brought for me, what knowledge it brought for me, and compassion. Because I got to then see that we carry a lot of trauma from stories that just kind of, once they break, they continue to evolve and fracture, and the difference gets bigger and bigger. I mean, we see this happening with India and Pakistan. I mean, I tell people that Hindi and Urdu are the only language in which you speak the exact same thing, but you write it in two different ways. It's a very interesting part of the world that we come from, where we're all united in so many different ways, and yet we're told that we're separate. To me, that is the fractured story of, if there's a story that is not making sense or is not productive, is not leading to people growing and evolving and developing cohesion, then there's something wrong with that story. It's either, you're right, like you said, incomplete, hasn't quite been resolved yet, because all the other pieces haven't fallen together, or we haven't gone looking for them, or we're missing pieces. That's the other part of the fractured story. Like, I put together this story starting at the age of 11, when I started to read. My first book in reading about the partition was something called Freedom at Midnight. And that filled in so many gaps for me as an 11-year-old, reading okay, this is what happened. This is history, how it evolved, because I wasn't taught that in school. And so reading about, different pieces of history helped me to really repair some of these stories for myself, so I didn't experience a fracture within myself, because I think what Dr. Shora was kind of doing in that moment was letting me know that there were people from Pakistan who loved Bangladesh, who loved Bengal and loved the culture and the people. And there was a lot of cross traffic going on at that time, before partition, before the disturbance. And that's what he was letting me know, that there was a sense of repair here. I was too young to understand that, but I really hold that moment with him as a moment where he said that, no, there's more to the story.
Yeah.
Yeah.
Beautiful. So just to recap, right? So you've mentioned the value of narrative medicine or storytelling for undergrad medical education, as well as for PGME residency training as well. Let's think about the crisis of burnout, right, and healthcare, particularly intra and post-COVID. I'm assuming that we are in a post-COVID phase now. So, how do you gauge, or how do you incorporate, perhaps, or see the value of narrative medicine as a countermeasure to burnout and compassion fatigue or empathy fatigue, and so on?
Yeah, absolutely. This is the part that really became highlighted for us as well over the COVID-19 pandemic. And COVID became the big story that we were all living together, and there were many opportunities for storytelling that came about. One of them was called The Nocturnists, which is a podcast and run by physicians, and it was really collecting the narratives that were coming through, and we all saw this. We all saw YouTube and social media. People really needed to share their story. And I think in crisis, we have to put it into words so we can understand what is happening, you know? And through it, we understood so many commonalities between all of our stories across the world, right? What was happening in Italy, was happening in Pakistan, what was happening in the US. We all united over this one story that we were living. And so one of the things that really started to interest me within COVID-19 was, okay, we're all experiencing burnout. How are the stories going to help us to connect with each other again? So really, when we went remote, stories became so important. Now I think it's become where, you know, we've all learned to put a little bit of space in there to connect with people. You know, digitally, we don't just go to like, okay, business as usual. It's like, okay, what, you know, where are you at? Where am I at? Let's connect. But what I'm trying to get at is that meaning in medicine, that purpose in medicine is what was shaken by the COVID-19, pandemic. I believe, because for me personally, at least, it became a big kind of, what do you call it? Like a jolt, like a hurt on our sense of capability as physicians, as a healthcare system, because all of a sudden this thing that was supposed to not break down broke down, right? The system that was not supposed to run out of things ran out of things, and we were left helpless, you know? And in that helpless state, we started to use things like Story Slam. We got some of our most, I would say, heart-rending stories out of that time, right? Because there was so much that we were all going through. And so stories became kind of like essential tools of exchanging meaning. When you have a mask here and you can't smile and you can't frown, you know, you get better at observing people's stories or being communicative about your stories in a much better way to help communication. So I think that piece was there, you know, that in the more near past. But I think when you talk about the physician's suicide, you know, the other epidemic, in 2015, I was at the TED Med conference, and the first speaker was this woman called Pamela Wible, Wible, and she has become kind of like the person that's ostracized by mainstream medicine, but is the one that suicidal physicians turn to all the time. People who are at the end of their rope, and either they've been broken down by the healthcare system or by the training system, and are just suffering. You know, these are physicians who have, in America, it's really strange because physicians start out with $200,000 of debt. You know, that is an incredible burden to carry while you're trying to go through this training process. So, you know, no wonder people were starting to just, you know, burn out. And as healthcare has become more digitized, more remote, more about RVUs and more about throughput, you know, the physician's sense of who am I and what am I doing in the middle over here? You know, can somebody else do this job better than I can? Right? Like I, you know, there's this difference between what you can do with the knowledge that you've gained in medical education, when it's about, you know, just the mechanistic part of medicine, or is it the creative and innovative part of medicine? And I feel like both of those things have to develop together, right? And if the person is being forced into one and not being able to be creative, able to, you know, take the sacrifices they made for 8 years of their lives and create some meaning out of it, as to, you know, designing the career that they feel would use their talents and their you know, learning and their experiences to the best of their ability, they're going to get burned out. So I was shocked by that talk, and it's on TED and, you know, on the TED blog, and you can watch it. So physicians have a 3 times higher suicide rate than the general population. And then what the studies have also shown, that when you have a bunch of students come into medical education and then you check on their empathy scores, the empathy scores go down. We know this, right? So something about us about the education system itself erodes the one thing our students come in with that we want to preserve, you know? So just the idea that, you know, stories and this meaning and work is one of the drivers that either can prevent burnout or can push us towards burnout was something that was put out by the AMA in 2017. So all of this is, fairly new within the last 5 to 7 years, that even the emphasis on physician suicide, wellness, what we can do at work to improve the factors of burnout have come in. And if you look at the American Medical Association's 2017 kind of like drivers of burnout, you'll see that there's, it's a hexagon, there's 7 of them, and right in the center is meaning in work. How do you develop the meaning in work? And around the sides are, workload and job demands, work-life integration, social support, community at work, organizational culture and values, all of that comes in. But in the center of it, all of that creates your meaning in work. And so to have self-efficacy around that, to be aware as a medical practitioner that, it is up to me to find my meaning in work, to build it up, to create it, to discover it, or excavate it, or if I've lost it, to go out and find it again, because it's so important to the longevity of somebody, and it's really sad when we lose a physician to suicide, because you think of, it's just sad anyway, right? But you think of the amount of work that person has put in all their lives to be the best version of their healing selves that they can be. And for some reason, the system around them cannot support that, cannot give value to it. And so that's why I think there's been a sea change in medical education among some of the top, medical schools, is to bring in this idea of coaching. So actually having medical education coaches, and I'm one of them for the class of 2026. This is the second year we're doing it. And it is so important because just like in athletics, right? You have an athlete who has all of these skills, they have talent, they need to be developed, they need to have resources, but they also have to have the coach who's looking out for them, who is not, I'm not evaluating them. I'm not even mentoring them. I'm just there to make sure that, okay, you're new to the city. Have you settled in? Are you making friends? Do you have a process in place for what you do when you're stressed out that doesn't involve negative coping mechanisms? Are you building up a series of habits that will sustain you for the rest of your, career? And starting those early, and that awareness early, I think will lead to, we hope will lead to, physicians who are resilient in the healthcare system that's coming, forward. So that's where I think burnout kind of fits in with narrative, because to create that meaning in work, you have to have facility with writing stories.
Yeah. Fabulous. That was really well put together. Thank you for that. And people online, if you have any questions or comments. No. Yeah, go ahead. Speak up. Yeah.
Looking into ways or certifications or any means of where we can take this step forward. And during my medical school years, I used narrative medicine as my coping mechanism, as my way to deal with the upcoming physician burnout that I could foresee out there. So I see a lot, like previously APU has had a workshop. There are 2 universities offering master's courses there. One is even offering a certification. So, but the one thing that always stopped me from going ahead was, why do we not have something of that sort in a Pakistani university? A similar, maybe proper certification course, or maybe include that as a part of the course in undergrad, something like that. Because we know our physicians are working in such low resource settings. When you go to the public sector hospital, the conditions there, they're just terrible. And here, maybe due to the culture and the factor of religion coming in, the physician suicide rate is not as high, but if they had the option, I'm sure it would be as alarming. So I feel like those of us who are huge advocates of narrative medicine and we feel strongly about it, it does put some sort of duty on us to advocate more for that, come up with something that streamlines it and gives people more access to using the writing skills also, narrative medicine also, as something that can be promoted and that they can use to their advantage and also to deliver better care. Of course, the more empathetic a physician is, the better they care for themselves, the better care they'll be able to provide to the patients.
Thank you for that. Were you able to hear that?
I heard most of it, but can you just summarize the question?
So what's the question in there?
My question was that, of course,
What can we do in Pakistan? Okay.
And how would that
Okay. Okay. So question, our first question is, so we know it works, we know that's important, but how can we incorporate narrative medicine in Pakistan in a low resource setting? And so what thoughts would you have around that, if any?
Yeah. Oh, absolutely. Thank you for that question, by the way. Who am I talking to?
Arfa Masiyuddin. Dr. Arfa Masiyuddin is currently a master's student in Health Policy Management. And she did her innovation fellowship with us as well. So 1 year innovation fellowship.
Excellent. That's a really good question. And you're absolutely right that, these elements have to be local. The part that works here and the part that works there may be slightly different and may have a slightly different emphasis and a purpose. And when you've asked about narrative medicine in Pakistan, I mean, Pakistan has its own very rich literary history. So I think one of the ways that we've done that over here is we've actually reached out to practitioners, writers, poets, people who do creative work. We had a person who does improv theater and actually teaches theatrical, skills to come in and do an afternoon workshop with us. And we started by becoming informed by the other people in what is this umbrella of humanities. The humanities is really wide, all the way from anthropology to ethics to art, music, storytelling. Just throw the net wide and becoming fearless in being that person in the middle that says that, yes, I'm about narrative medicine, because a lot of opportunities came to me that way. People were like, oh, you've written this article and you've expressed your interest, and I know this one person who said that they really like this, and I'm going to give them your number. And building those networks and enabling. So many students came to me, in the last few years. They're like, I really want to write down my stories for my clerkship. I've gotten them down. I'm a storyteller at heart. I really want help in collating them together and maybe editing them down and really finding what purpose I can put them to. So things like that, leaving the door open for projects to come to you, is and becoming known as the person who is supportive, and kind of finding spaces for it wherever. If there's university programming happening, stick a poem in there. stick something in there that shakes people out a little bit of their usual everyday cognitive left brain modality. Remind ourselves when we're all together in a big group that we are developing both sides of ourselves, the logical as well as the emotional. And if we have more of a bias towards the logical, well, we miss out on all of this emotional development that can happen. And that's what narrative medicine is. It's emotional development of the physician and of those people. And I will say, I always carry this one word with me, one sentence with me, because it was so useful to me in thinking about this. And when you think of building up the individual, I think this line, please excuse my Urdu. खुदी को कर बुलंद इतना कि हर तकदीर से पहले खुदा बंदे से खुद पूछे बता तेरी रजा क्या है. Right?
Allama Iqbal.
Allama Iqbal. And there's so much meaning there. I mean, if we just took that sentence and we sat and just talked for 15 minutes about what does that mean to you? When did you first learn about it? How do you interpret it? This act of interpretation that we're doing is narrative medicine, and it doesn't, that's the beauty of poetry and art, is that it's open to so many different interpretations that it brings people together to address it. So I think that's what I, for Arfa and everybody else is just, open yourself up, become about it, take ownership of it. Because you know that this is so helpful to you and others, look at places where you can have this impact. If you have a couple of students and you've got 30 minutes, do a 15-minute writing exercise. Write a story about what you just observed today, on your field trip, for example. And let's go ahead and share. And people are so eager to share their stories. That's what we do in the third year of clerkship, because that time in your medical education is when the stories are new. You're looking at the stuff for the first time. The impressions are indelible, And so to insert writing into those kind of transitory points, when you're transitioning from preclinical to clinical, for example, or around graduation, just before graduation, when you finally have time to be like, okay, I want to think about what I'm doing with my life, or I want to think about, where, what we've already been doing in medical school and how I'm going to take that forward. So, thinking of those opportunities.
Great. So I think if Arfa, your question was also alluding to lack of systems level narrative medicine, if I may. I think we're not there. I don't even know whether I've been here. I've been in Karachi. I've been at EQ for 10 years. So, there are challenges over here, obviously, just like any medical school. But I think we have our unique challenges. The curriculum is already overflowing. And so you're going to be incorporating more into that. But you are a writer, I know, because you've shared some of your writings with us. So I think I was writing as well, not realizing that I was also somewhat indulging in narrative medicine, right? So putting together those stories becomes really important, not just for you, but also others as well. Could be content for others to learn from. And so it could be an informal approach, perhaps, not so much a formalized tier 1, 2, 3, 4, 5, but an informal approach to narrative medicine, and people might benefit from that even. So just a thought. So do we have any other questions? I wanted to, any other questions, comments online?
No, not yet.
Okay, so let's think about, what I consider to be Simi's evolution or progression. So how has narrative or narrative medicine or storytelling got you to think about moving into your current iteration, which is psychedelic and integrative medicine? Were there links there? Maybe there weren't links there, but why, how and why has that happened or is happening as we speak?
As we speak, it's happening as we speak. It's a very new specialty, I would say. And the promise is that board certification will be coming down the line in the next year or so.
Wow.
So psychedelic medicine and storytelling are very much interconnected, at least for me. They kind of, it felt like the next reasonable step to take within this context. So when it comes to, for example, storytelling and mental health illness, one of the things that people have written about and talked about is that depression, for example, if we just take that, can be like a story that's broken or story that's kind of circling in on itself constantly in a groove, and it's hard to break out of that groove of the story and to tell ourselves a different story out of the same set of facts. And psychedelic medicine has the ability to help us to loosen our default mode network, is what they're finding, and give us a space to consider different options for the same number of, let's say, events, or for the same kind of set of facts. And so in that way, psychedelic medicine seemed to be a tool, a resource to use that can help with this idea that if we tell ourselves our stories in a different way, or if we can live a different version of our story, we can move towards productivity and health, and that psychedelic medicine can unleash that process or make it much more predictable. Because having struggled for the last 15 years to do narrative medicine, as we're talking about, even in a space with very highly intelligent people who already do some writing, it's really hard to get people to kind of, you know, switch away from all the busyness of our world to be like, yes, I want to use this part of my kind of brain to think about my story because it'll help me heal. It's very difficult. Louise DeSalvo is the author that I really connect with over this. She's written a book. It's on my shelf. It's called The Healing Power of Stories. It's a really you know, wonderful way of looking at how rewriting our stories can help us understand them better and heal. And so in the same way, in the psychedelic space, and psychedelics, when I talk about psychedelics, I'm only talking about the legal, you know, ethical use of psychedelics in the medical space, not the recreational, because I'm not qualified to talk about that. But ketamine is the only legal psychedelic. As you all know, ketamine is a dissociative anesthetic that is used very, you know, kind of ubiquitously in the ER, OR, everywhere. And as a pediatric sedationist, I was very used to using it with children, you know, chronically ill kids. And so for me, when I learned that the sub-anesthetic dose of ketamine can produce a psychedelic experience, and that was something that, one, is helpful to a lot of people with mental health crises, and the numbers were starting to really be very impressive, you know, to where it can save somebody from a lifelong kind of, you know, dependence on medication, for example, because a psychedelic treatment for a mental health disorder could be the last time you need a treatment for that mental health disorder. For addiction, for sure, we've definitely seen an improvement in people with smoking cessation and alcoholism, have shown huge kind of just like inroads into the numbers. When you look at, if you're doing, you know, randomized control studies and you know, go ahead and compare those two groups, the psychedelic medicine is outperforming the standard of care. So that really, you know, pushed me to realize that, oh, this is a field that's going to need a person like me. That's why I went into it. I was like, with the experience I have, with the understanding I have of personal transformation and the kind of interpersonal, you know, kind of building up of experiences that, you know, transform people, that's what I've done in medical education and using narrative medicine, that this was a transformative medicine that would basically just supercharge that for me, which is I think what's happening. But it's early days yet, so I'm excited.
That's really interesting. And so and it's exciting as well, right? Because it's something that we don't tend to hear about, like not the medical aspect of it. We tend to hear more about the recreational aspect of it, and so, and people then tend to just you know, judge that, okay, there could be something more than other than just recreational over here. So
and I can describe the difference between the two a little bit, just because it is very starkly different. It's very different if you go ahead and take mushrooms or psilocybin or LSD by yourself, you know, and you haven't had that preparation and you don't have somebody with you who can support you during that journey. Those are the two things that I would say is critical and can make all the difference, is to have a non-judgmental person who's experienced in handling what can happen in the journey. Because in the journey, people can experience, you know, near-death experience, they can have out-of-body experiences, they can even experience their own birth. There's an interesting kind of aspect to this that was studied by a psychiatrist called Stanislav Grof, who invented the technique of holotropic breath work. which is actually when the psychedelics were banned, holotropic breath work became the technique to put people in their psychedelic, space. It can still get you there. I think it basically blows off your CO2 and changes your blood chemistry. so that's the, kind of thing. So once they started to do that with holotropic breath work, one of the pieces that he contributed to was this idea of perinatal matrices, this idea that at birth, because of the birth process and how going through the birth canal has like a predictable kind of, 4 stages is what he described, a predictable kind of emotional / felt experience, of being trapped and then finding release, like everybody has had some sort of birth experience that we obviously don't remember, but under this medicine, there are aspects of it that can come back to us. So that is it's psychedelic is mind manifesting. So basically it manifests your mind. It basically allows you to study what's inside your own mind. Is the clearest way I can talk about it. But yeah, it's very interesting.
So one follow-up question to that is that since you're kind of like exploring this area and you're practicing it at the same time and you're learning, how can we help in your journey? And then conversely, in return, we're learning from you as well. So, but how do you see our infrastructure or our team over here or group over here? Because I think it could be a self-selected group of people who are really interested in what you're doing and what you're learning. And so,
yeah, how
could you use this space, if I may, I guess?
Yeah, absolutely. I think I would, definitely think about it from the perspective of collaboration. It's always about collaboration because problems are local, and I think solutions need to be local. But definitely expertise can be exchanged. And one of the pieces that I can convey to you is when I learned about ketamine, for example, I realized that set and setting, which means the person's mindset when they're going under with ketamine, and the setting, which means what's around them while they're in the ketamine, is hugely important. And so one of the pieces that I learned that was shocking to me was that when we're in the hospital giving somebody ketamine and we have an emergence reaction, right? We know that coming out of ketamine can give you a really terrible psychotic looking emergence reaction. It's very terrifying. That we can decrease that emergence reaction if we prep our patients better. To say you are going to feel separated from your body. You may even experience some nightmare-like, scenarios, but know that you're safe. Doing things like decreasing the noise in the room, decreasing the interruptions, decreasing the volume of things to make a more peaceful environment can help the patient have a better experience. So even just, how we can help each other is to just pay attention to the experiences that we're all having and taking that knowledge to improve it. And that's, that's the key here is we always have something to learn. There's always something to learn. One point that I do want to support is that you did mention that formalized and informalized curriculum for narrative medicine to our first question. And that's exactly it, is that it's very hard to formalize a narrative medicine curriculum. It's better to go informal because it's such a small number of people. You don't want to have people kind of resent the field because we're like, acha, you've got to do narrative medicine now. You've got to do narrative. It's like, no, if you understand it, you understand it. It's a skill you can develop, but you have to come to it because what you bring to it is just as important. You can't teach somebody. This is not learning English literature, It's not a body of work that we have to learn and memorize. It's something we have to feel and understand. So it's really different.
It's a very good point. Yeah. And so I think we're coming to the end of this session, but I think there's so many things that we could kind of keep talking about or exploring, or maybe there could be a follow-up session. We have discussed the potential of a workshop of some kind, because we did this narrative medicine workshop the first time we worked with Simi, and so it could be I don't know, something like version 2.0 or 10.0. I don't know. It's been several years in between, and we have a chapter of Medjack as well. So different things one could try, right? So
Yeah.
it doesn't have to be writing. It could be role play. I don't know. It could be acting, or it could be illustration or photography.
Different
But we
forms.
have a really nice space over here. If you,
Mhm.
what you can see over here, this is the D lab.
Oh.
Right? This is the D lab, and it belongs to the Faculty of Arts and Sciences. And CCIT has a co-working space here. So I think this space itself, you
Oh,
can't
yeah.
see it, but we've got windows. It's on the 10th floor, and you can get a fabulous view of the lakes. And so I think a place of this kind could be used in for narrative medicine, and we could define
Yeah.
it different ways.
Absolutely. Like, one of the things that I can, we're going over time, but I can definitely give you a sense of one of the projects that we've done. It's the art gallery, patient artist art gallery talks. We're lucky here to have I kind of stumbled on him, but that's because I kind of just cold called different people at galleries. And I said, hey, can we use your gallery space to do this observation exercise for medical students? And this guy, Ted, he was like, I've been trying to get through to you guys. He's old. He's like in his 50s. He's like, I've been trying to get through to you guys. I work with UCLA, but they're so far away. I want to work closer. And it turns out he had Gaucher's disease. The inclusion, the glycogen storage disease all his life, and painful episodes, just like in sickle cell, all of that. So spent his whole life in the hospital, but started to make art, and that informed his art perspective. Scroll forward to like in his 40s, the enzyme replacement comes out, and all of a sudden Ted goes from making art about his pain to having no pain, having nothing to make art about. Right. And so he meets this woman in a wheelchair who has this long scar down her back, and she's gorgeous. She just like is wearing this backless dress, and he connects with her, and she says that you've got to do something for other people. In short, she talks to him that night. He gets into a big, kind of like tizzy about it, and he has an idea. He takes his paints and his paper, and he goes to her house that night, and he says, I want to make a print of your scar.
Oh.
And he puts the paint on her back, on the scar. He puts the print on, the paper on, and he takes the paper off. And then he proceeds to work on that sheet of paper with that print on it and tell her story. So if you look at Scarred for Life and Ted Meyer, you'll see hundreds of them, scar prints that he's done and told stories about and published books about. But what he realized was as soon as he put that scar print up there, people started to like drop their pants and show him their scars. They're like, oh, I've got a scar too, And he realized that everybody's got a story about their scar that is very relevant to them.
That's right.
Interesting stories, crazy stories you've never heard. This one guy who had his hand blown off, with a firework, and had, that whole thing where they open up the peritoneum and they put the hand in there, and then, the old school way that they used to do it to preserve the hand. Apparently his mother had the exact same thing done to her, when she had something happen, same procedure was done to her. So just like stories. So basically you've got an amazing space to just invite people in, whoever's telling stories out there that connects with you, that you feel is going to be important. So, long story short, now 10 years forward, Ted and I put together a budget and asked the university to pay us to put up 4 art gallery shows a year. So he invites other patients who do art, just like he does, about their illness. And we've invited that into the medical school. So lunchtime pay, students come, we provide lunch. And then let's say it's a cardiology block, and the artwork that's out there is about the cardiac system. And you see all these wonderful things, and you have the cardiology professor sitting there kind of also talking to the patient, and having a real conversation about, tell us about your experience of the illness. How did this impact you? And what was that like? And what is it that you're trying to express in your art? And that felt experience. And we have 100 to 150 students show up because it is so fascinating to hear somebody talk about their illness experience. And that's narrative medicine, that's sharing stories, but you don't need words. So that's the other kind of, aspect to it that you guys have in a Faculty of Arts and Sciences, I'm sure you'll find some partners to help you out with that.
Yeah, a great idea. We thank you for that, and over to you.
Yeah. Any last messages? Take-home message?
Well, yeah,
Take-home message is always pursue what interests you. You never know where it's going to lead you. I remember reading Vikram Seth's, Suitable Boy when I was in med school, and really being fascinated by the narrative in that, and had no idea why, but I pursued it, and it leads you to where you are supposed to be going, if that makes any sense.
That makes a lot of sense. Yeah. So thank you for joining us, people who are here with us in person, people who've joined online. Thank you for the session, and thank you so much, Simi.
Yeah, it was wonderful to talk to you both.
Yeah, we hope to connect with you soon.
Right, take care.
All
Have a
right.
good day. Thank you.
Thank you.
Bye.
Thank you.